Hello, everyone, and welcome to our Facebook Live session on lung health in observance of Lung Cancer Awareness Month. My name is Diana Rosito, and I'm a wellness coach at Baptist Health, and I'll be acting as your moderator today. I invite everyone to tune in for the entire session if you can, because it is a very important session. There's going to be a lot of great information shared, and we welcome you to join the conversation. We do have a comment section that we will be monitoring for any questions that you have. And so please make sure you let us know you're here. Just even if you want to say hello, we'd appreciate that. So without further ado, I'd like to introduce our special guest speaker today, Dr. Deb. So Dr. Deb, can you tell us a little bit about yourself?
Sure. I'm a thoracic surgeon. I specialize in the surgical treatment of lung, esophagus, and other cancers in the chest cavity.
Hey, excellent. Now, which location are you out of?
So I am currently at the Baptist downtown campus at the MD Anderson Baptist MD Anderson Cancer Center. We also have a clinic at the South Campus as well.
Okay, very good. Well, Dr. Deb, thank you so much for being here with us today. It's very important, and we appreciate your time. So you have a lot of great information you want to share with the viewers today, and information we all need to know about. November is a very important month, and we're not talking about Thanksgiving and family gathering, right? We're talking about Lung Cancer Awareness Month. And with any health observant month, it's a great opportunity to learn more about that health focus, local resources, and latest treatment. And this is why we do these talks, because we never know if there's someone out there who may need this information right at the moment. And so we want to understand why Lung Cancer Awareness Month is so important, and we want the viewers to understand how it's so important. So, Dr. Deb, if you can just kick us off and give us some information about that.
Absolutely. Lung cancer continues to be the number one cause of cancer-related death in the United States. Over 230,000 new cases are diagnosed every year, and this is based on the American Cancer Society's 2021 statistics. And over 130,000 people die from lung cancer every year, which is more than colon, breast, and prostate cancer put together.
Wow.
So it's a major health care burden. And a significant issue that all of us should be aware of. The other important thing is, of course, smoking continues to be the number one contributor to the development of lung cancer. And although there has been a decline in the rate of smoking among men and women in the United States, and there's also been a decline in the incidence of lung cancer, it still continues to be a major problem.
So, well, that's good news, Dr. Deb, that there's a decline in it. You said smoking?
Smoking, as well as the incidence of lung cancer in men and women.
Wow, that's very good news, but yet it still is something that is important because it's still an issue and we need to be aware of it. So I'm always stunned at the statistics of the amount of people with lung cancer or the amount of people being treated with lung cancer. So can you walk us through the process of how one would know? Are there any symptoms that they typically, notice, or where do they go if they want to get it checked out?
Absolutely. Lung cancer is sort of a silent, insidious process until it rears its ugly head. So most people, by the time they develop symptoms of lung cancer, and that could be a cough, weight loss, pain, shortness of breath, it's usually in an advanced stage, unfortunately. So the goal of treatment of lung cancer, number one, is screening.
Right.
So screening is a secondary prevention process, meaning that it doesn't prevent us from developing lung cancer, which is, of course, smoking cessation, but it can detect lung cancer in earlier stage before the patient has symptoms. And an earlier stage portends a better prognosis. So lung cancer screening is very important in the overall algorithm for management of lung cancer.
Okay, thank you. And so, if someone is watching right now and they know that screening is important, so where do they go and get the screening? What does it involve? And do they have to be a certain age?
Absolutely. So screening is so the screening study was published in 2011 in the New England Journal of Medicine, and it was a landmark paper in that it was the first time in modern medicine that lung cancer screening was shown to be beneficial in terms of reducing death rate, mortality. And this study showed a 20% reduction in the lung cancer mortality. And this was also, interestingly, the largest study funded by the National Institutes of Health, with over 55,000 patients, about half in chest x-ray and half in an annual CAT scan uh, evaluation. So the screening patients received the CAT scan for 3 years, once a year, and they compared that to patients that received just a chest x-ray. And they found that the patients that had a screening had a significant reduction in lung cancer mortality by early detection.
Wow.
In terms of who qualifies for screening, that study, the NIH study, looked at a specific age group of 55 to 74 years of age. They looked at patients that had a 30-pack year smoking history, that were active smokers or had stopped smoking within the past 15 years.
Hmm.
They also had to have an absence of symptoms of lung cancer. So no recent weight loss, no recent pulmonary symptoms. And what they what that screening criteria, that group of patients that they looked at, has been expanded, if you will, to include other patients with less smoking history and perhaps younger and older age. So I know the Medicare, the CMS, Center for
Mhm.
Medicare Services, is actually looking at expanding that to age 50 to 80, I believe, or 77. Uh,
Okay.
and and also to include patients that have less smoking history, so not 30-pack year but maybe 20-pack year history,
Mhm.
and that is currently being looked at as well. So more to follow on that, but for right now, that specific age group is what was recommended in the study to be screened.
That's very good. That's I'm sure people are looking forward to that as well. So before we get into any kind of treatment options, are there different types of lung cancer?
Yes, there are. There are a variety of types. When I talk to the patients, I explain that there's two major types. There's small cell, which is about 20% or so of lung cancers, and then there's non-small cell, which is the other 80%. Under non-small cell lung cancer, there's different types. There's adenocarcinoma, which is a glandular type of cancer. You can get adenocarcinoma from the colon, from the prostate, from the breast. So it's just a general term for glandular cancer. There's squamous cell carcinoma, which is resembles the lining of the airway, and it usually arises from the lining of the airway. Adenocarcinoma and squamous cell carcinoma probably comprise about the vast majority of non-small cell lung cancers. And then we have a variety of other less common types, such as large cell carcinoid, adenosquamous. Some cancers don't resemble any tissues, and we call them undifferentiated. So there's a variety of others, but most patients will have either adenocarcinoma or squamous cell carcinoma, and
Okay.
a few will have large cell carcinoma.
Okay. Thank you for clarifying that. Now, Dr. Deb, I know that there are some images you wanted to share. Now, oh, here we go. Thank you so much. So, is this a good time to share this?
Sure.
Okay.
I wanted to just briefly talk a little bit about the treatment of lung cancer because that's what everybody wants to know.
Right.
Uh, when we have a diagnosis of lung cancer, we first want to determine the patient's stage. What stage is it? Is it stage 1, 2, 3, or 4? Because that's what dictates treatment. And when we have an earlier stage cancer, something that's localized or maybe local regional, meaning it's within just the one cavity in the chest, then we talk about surgery plus or minus other treatment modalities. Other treatment being radiation therapy, chemotherapy, in addition to surgery. When we talk about surgical removal of lung cancer, this picture depicts the variety of different types of lung cancer operations that can be done. It's not just one operation, there's a variety, and the operations are tailored to the size of the cancer, the location of the cancer, and very importantly, what the patient will tolerate. If you look at the lung cancer patients, our average age or our median age is 70 to 72.
Wow.
So we're
Okay.
dealing with an older population of patients, and about 25% of our patients will have significant emphysema or COPD. And so we have to take those things into account when we're discussing removing a portion of lung that that person may be using to breathe every breath. And so there are a variety of operations. That's what this slide shows. You can see you can take the entire lung if you have a very large tumor. That's called a pneumonectomy. The lung has. Let me just regress for a second and say that the right lung has 3 lobes and the left lung has 2 lobes. And so the standard operation is taking either 1 lobe or 2 lobes, so a bilobectomy or lobectomy. And then, believe it or not, like the liver, the lung is broken up into little compartments, like little baby lobes. So, as an example, the left upper lobe of my lung has multiple small compartments that make up that left upper lobe. There's an apical, there's an anterior, there's a posterior, there's a lingular. So all these little segments. And why is that important? Well, maybe I have severe emphysema from smoking and I want an operation to remove the lung cancer and I have an early stage lung cancer. Then the surgeon, if they're skilled enough to do the operation, can do a segmental removal, just removing the little baby lobe and saving the rest of my lobe so that I could continue to breathe and maybe avoid needing oxygen after surgery. And so the last two, segmentectomy and wedge resection, are less than lobectomy, which is taking the whole lobe, um, operations to spare someone's lung tissue, to reduce the problems after removing a portion of lung, reducing risk, and things like that. Um, these operations traditionally have been done with a large incision between the ribs on
Okay.
the side of the operation. Here at Baptist MD Anderson, we specialize in minimally invasive surgical techniques. So using either a robotic platform or a videoscopic platform, which is a camera. And we can do all of those operations, including a bilobectomy and a pneumonectomy, which is removing the entire lung, in some cases using these small incisions.
Wow.
And the advantage to the patient is multiple, but one of the biggest advantages is that they have less pain. They return to their regular activity level faster.
Mm-hmm.
Um, and if you look at the treatment of lung cancer today, we do have a whole arsenal of immunotherapies, all kinds of chemotherapy options, and also oncologists are more uh, proactive in offering chemotherapy after surgery, even in somebody who had an early stage cancer that was considered curative, to keep the cancer from coming back. And so if you have a less invasive operation, you're you're back on your feet and back to your regular lifestyle, and you can start these treatments much faster than if you were still recovering from this big incision for 3 months and so forth.
Right.
That is probably the biggest benefit of doing minimally invasive surgery for a patient, is that they're ready to go on with any other additional treatment as necessary.
And that's really good to know because, as you know, like in life right now is busy and people are just, okay, I have to have this, but I need to get back to my normal daily routine. And
Right.
so I appreciate you going through the treatment options as well as the viewers understand the anatomy really of the lung and the different compartments. That's really interesting. I've done something similar to this last year, but I wasn't aware. So this is good to know for my knowledge as well. So Dr. Deb, just to recap, so someone may or may not have symptoms, right? But they can have a lung cancer screening done if they have some concerns. And then the doctor or you would tell them, what stage, or it's important to identify the stage. And then you talk about treatment options, which you just discussed. And that Baptist MD Anderson has minimally invasive options. And then post surgery, what does that look like for the patient?
Post surgery, there's a few days in the hospital. Um, the median is about 4 to 5 days, which is the national average. That's our average as well. And then maybe somewhere between a week and 3 weeks of sort of recovery at home. I've had some patients go back to work the second week after surgery.
Wow.
And I've had some patients need about a month at home before they're back full speed. So everybody's different, and a lot of it depends on their functional level before the operation,
Right.
and also how much lung tissue we take out. I think that's one of the biggest things that I think is around the corner in terms of saving lung tissue for early stage lung cancers.
Okay. So, what risk factors do people or should people be aware of when it comes to lung cancer?
Sure. Smoking is, of course, the biggest risk factor. 80% of all lung cancer deaths or smoking deaths are due to lung cancer. So you're talking, and that includes secondhand smoke as well. And then probably the second most common cause of lung cancer is radon, which is a byproduct of, I believe, uranium decay, which is found in the soil and in rocks. And radon is a gas that can accumulate inside homes. It's probably not a big deal in Florida because I'm somewhat new to Florida, but no, we don't have basements here. But having grown up in Virginia, everybody has a basement, and so that's where radon can accumulate. So radon. Now, that's not saying that you can go outside. You're not going to get any kind of a significant exposure by just being outside, but it's when the gas gets concentrated. But if you look at studies, that's probably the second most common cause of lung cancer after smoking is radon. Other things like asbestos exposure, we think of asbestos as being linked to a type of cancer called mesothelioma, Marshall's. But actually, asbestos is also associated with an increased risk for lung cancer. People, miners, people working in mills, the shipyards, former Navy folks are people that may have had exposure to asbestos. Other things, arsenic, diesel exhaust, these things have been looked at, and maybe there's a link. They're sort of generalized carcinogens. They increase the risk of a lot of different cancers. In terms of e-cigarettes and marijuana smoking, which is something that I get asked about, I don't know. There's not a lot of information on these products, and they're linked to development of lung cancer. You could sort of infer that tar and byproducts of tar can certainly increase your risk of cancer. And so I would say that probably there is air pollution, things like that. One of the things that's often forgotten is also history of previous radiation. Now, as a center like MD Anderson, we do see a wide variety of patients, and some of whom have previous history. So women that maybe have had previous breast radiation after breast conservative therapy, or people that have had certain types of lymphomas where they get chest radiation, may be at risk as well for the development of lung cancer down the road. So those are patients that should be aware of that risk and should be followed regularly.
Thank you. So I'm so glad you mentioned about vaping and marijuana, because it is, when I was doing some research, some of the common questions asked were those. So thank you for letting the viewers know that there's not enough information on it. But of course, we should always be cautious or not do those things at all, and just, for our health, just in general. So are there some myths out there that you can discuss with us and debunk them? Just, the most common ones, if you were to pick some.
One is that patients, once they get the diagnosis of lung cancer, they feel like that the cancer is now going to get out of control. And so I always tell people that we have to make sure we get all the data before we plan your treatment, that just because the cancer has been noticed doesn't mean it's going to now escape and metastasize. Mm-hmm. Another common myth is that once we go into the chest cavity to remove a cancer, that it's going to spread at that point. That's also never been validated scientifically. There are some basic principles that all cancer surgeons follow when they take out a cancer, that are taught in our training programs when you remove a cancer, so that to minimize fracturing it and spilling it and things like that. But just going in the chest is not going to cause the cancer to spread. Those are probably two of the most common questions I get asked by patients.
Well, thank you, Dr. Deb. Thank you for going over that. So let me just pause for a moment and see if there's any questions from our viewers. So I don't see any at the moment, but I would like to give you an opportunity, Dr. Deb, if there, for people who are watching, and sometimes with these virtual talks, it's sometimes hard to ask those questions, especially if we are concerned about ourselves or we have a loved one. But if there's any call to action or anything just from you that you like viewers to know, what would you like them to know at this time?
Well, I just wanted to just touch base on the lung cancer screening just a little bit.
Absolutely.
Because it can cause a lot of distress if there's something found on the CT scan that a patient may get for screening. So lung cancer screening is not necessarily detecting a cancer, it's detecting lung nodules that may or may not be cancerous. So, and that study that I quoted, the NIH study, about 25% of all patients actually had a nodule found. So it's pretty common. And so it can cause a lot of distress and sleepless nights. People are really worried, what to do, and I just want to reassure people that vast majority of the nodules that were found in that screening study, more than 95% were benign.
Thank you for clarifying. Thank
you. Just finding a nodule on a CT scan is not mean you have cancer.
Right.
It just means that we need to look further into this and evaluate it in a scientific and systematic manner to determine what it is.
Mm-hmm. Thank you. This has been so informative, Dr. Deb. Thank you so much for all the information and knowledge that you've imparted onto the viewers. And we don't have any questions or comments at this time, but, of course, just want to say thank you so much for your time. And also to let the viewers know that if you are concerned or if you think you may be eligible for a lung cancer screening, please have that conversation with your primary care physician. That's where it starts. So having that conversation with them, or even if you're concerned about a loved one, have that conversation with your primary care physician. And if you need help finding a doctor, you can call our Care Navigator team at Baptist, and that number is 904-202-4U. And we'll have that up in the comment section here as well. And that's 904-202-4U. And you can request an appointment online and get started if there are any concerns. And again, I want to thank the viewers for joining us. And Dr. Deb, thank you so much for your time. And a happy Thanksgiving to you and your family, Dr. Deb, and to everyone watching.
You too. Thank you very much.
Thank you so much.
Bye-bye.